We are going to learn about necrotizing or malignant external necrotizing malignant external otitis. This is a severe variant of acute otitis externa, which develops from the necrotizing inflammation of the external auditory canal. So because it's a severe variant of otitis externa, then etiology has to be the same with the acute otitis externa. And the etiology of acute otitis externa is most commonly Pseudomonas aeruginosa, but we can also have Staphylococcus aureus. And this disease usually develop in patients who have immunosuppressed or commonly in patients who have diabetes mellitus. So risk factors, I've already mentioned them, and the first one is all the adults that's 60 years of age. In addition to that, we have diabetes mellitus. In addition to that, we have immunosuppression, and immunosuppression varies from secondary to primary. It could be drugs, it could be infection, or it could be primary. Next is clinical features, and the first clinical feature that you're going to talk about is severe persistent ear pain or jaw pain. So commonly they'll have the same symptoms that patient who comes in with otitis externa have, but now on examination you're going to see granulation tissue. So they can present with severe and persistent ear pain and jaw pain, extension of the infection, because we say this is necrotizing inflammation. Then we can have extension of the infection to cranial nerves, and the cranial nerve most commonly affected is the facial nerve, which will present as facial palsy, in addition to cranial nerve number 9, 10, 11, and 12, and the spinal accessory nerves. So with that, you're going to have, with facial nerve, you're going to have facial nerve palsy, and with cranial nerve 9, 10, and 11, you're going to have dysphagia and hoarseness, and cranial number 12, that is hypoglossy, you're going to have tongue weakness. So that's how they're going to present. So in addition to that, you're going also to have conductive hearing loss, considering that the part of our conductive system that is being affected is external auditory canal. And you're also going to have red and swollen external auditory canal and periauricular soft tissue, and otorrhea, that is the discharge from the external auditory canal. So as I said before, the otoscopy findings or the examination findings are kind of the hallmark to differentiate, is this a severe variant form or this is a simple form of otitis externa. So on examination, you're going to see granulation tissue at the cartilage, especially at the bone junction of the external auditory canal, as you can observe here. So diagnosis, you're going to begin with the lab, that is most of the basic test. We're going to do CBC, we're going to see elevated WBCs. In addition to that, you're going to do basal metabolic panel, and in this you can also see elevated serum glucose in terms of diabetes mellitus, which is said is one of the risk factors, and also creatinine. ESR and CRP, these are inflammatory markers. You can also do culture of the ear canal to determine the etiology. In terms of imaging, we can do CT head with contrast, which is preferred initial study. In addition to that, you can also do MRI head, which is the best modality for detecting soft tissue extension and intracranial abnormalities. So with this, in addition to that, you can also do radionuclear scans. You can also do PET or CT scan. In this, it is determine the disease extension and also monitoring of the treatment. So in terms of the imaging, what are you going to find in terms of findings? You're going to see bone erosions, you're going to see soft tissue involvement, you're going to see intracranial extension, and you're also going to see abscesses. So in terms of treatment, we have antibiotic therapy, and we said that the most common etiology is the Pseudomonas aeruginosa. So in terms of the antibiotics that we are going to give, we are going to give anti-Pseudomonas agents. So it's not this delivery of antibiotics, or the mode of administration will be systemic and not local, and the duration will be 6 to 8 weeks. And you're going to give two anti-pseudomonal agents from different class, and we can give ciprofloxacin plus ceftazidime. We can also give piperacillin or with tazobactam. We can also give cefepime. So in addition to that, you can also do surgical biopsy to rule out if this infection is a fungal or a malignancy. So in addition to that, there's also a role for surgery. As we said, one of the things that you're going to find in imaging, you can rule out abscess, and I'm very sure it's one of the complications. So in terms of abscess, drainage or debridement. So complication, you're going to have osteomyelitis of the skull, which will manifest as most of the things that you've already said. And the first thing is the facial nerve palsy, which is the most common. And less common, you can also have cranial nerve 9, 10, 11, and 12 being affected. We can also have meningitis. This is an infection of the meninges. We can also have cerebral abscess. We can also have relapse in up to 20% of the